So this next topic, we're going to be discussing arthritis, so covering osteoarthritis and rheumatoid arthritis. So just to sort of do a bit of a quick summary before we go into a bit more depth, osteoarthritis is the general degeneration, so the wear and tear of the linings between the bones, so the cartilage. So generally that happens with age. Generally it's normal, sort of by the age of 40, 50. It's normal to have certain amounts of degeneration or arthritis in weight-bearing joints such as your knees, particularly if you've got an active job or if you're an athlete. So I'd probably say is about age 40 sort of can have sort of mild to moderate wear and tear in the knees. Things like shoulders, not as weight-bearing, but again, depending on your occupation. So jobs like decorators, they might have a bit more mild to moderate degeneration. Whereas rheumatoid arthritis is a systemic condition, so it generally affects multiple areas of the body. It's an autoimmune condition where the body basically attacks the lining between the joints. So very different conditions affecting different populations as well. So in terms of arthritis, what would we say is the main top joints that we see affected in clinic?
Knees and hips.
Knees and hips, straight away.
Yeah, straight away.
We're talking osteo.
Yeah, osteoarthritis.
Osteo, yeah. Well, probably more, yeah, like I said, that difference is understanding, because I think people do have a little bit, it's that kind of fully understanding the difference between rheumatoid and osteo, yeah. Like I say, that's why rheumatoid is quite, they do a lot of blood tests for that, don't they? And then there's a lot of, some of the medication around that, and then that kind of calms that inflammatory response, and it's just that. But
what sort of age would you say you see someone, if it's a new client and they're coming in presenting with sort of arthritis of the hip or knee?
You generally, I mean, again, all these are stereotypes. You're looking over 50, really.
Yeah.
50 plus.
Yeah.
But again,
it's not limited. These things are not limited to that.
Yeah.
But
yeah, we're getting into sort of specifics straight. All right, anyway, we're getting into specifics straight away. But recently, I've seen much younger female population with hip arthritis over recent, whether it's just a freak coincidence or what, but specifically it. Again, whether it's more coincidental or there's something in that, we're talking late 30s, early 40s.
Right,
and
okay.
seeing sort of early onset of hip arthritis.
That's interesting. One of my clients, they basically said it's that significant sort of severe grade 4 arthritis of a hip, and she is late 30s.
Yeah, same thing, 40s. That's the lady I'm thinking of, and it's generally categorised as an all person's problem, which isn't true. It's for numerous different reasons, but it is. Rule of thumb, yeah, age is a massive factor, isn't it? But it's just to try to put out there that it isn't limited to that.
Yeah.
You don't have to be over.
do you think you've got any signs of arthritis?
Me personally.
Personally,
yeah. You
Oh,
guys?
good question.
If you were to get a full body scan.
I definitely think my thumbs and my wrists.
Yeah, thumbs and wrists.
Yeah.
Think. Yeah, I think thumbs
And
possibly.
elbows more recently as well. Occupational or...
Yeah,
I don't think anything symptomatic personally for me. I don't think there's anything
that's kind of that was my point.
But
yeah.
I think if we had some sort of scan, there'd be onset of it.
And also there's loads of studies, isn't there? So that classic one where they've done so asymptomatic, so that means people without any pain, and they're looking at people over 50, and I think 50% of a large number of people as well. I think it was, for some reason, it was men for some reason, but a lot of them had sort of these signs of degeneration. So whilst that is one of the signs of arthritis, it doesn't mean you're necessarily going to have
your symptoms.
Symptomatic as well. And when we talk about, you said wear and tear, which is, that triggers me a bit, to be honest, because it's,
sorry for triggering you.
I was all right, I had to take some deep breaths, because there's an element of that where there is kind of natural wearing, but for the general population, that terminology, they're thinking it creates fear for me, and they think, because I'm using this joint, I'm going to damage it, so I need to not use this joint.
Yeah.
Okay, which the opposite is true. But when we're trying to sort of compare rheumatoid and osteo, we were sort of, like you said, and systemic autoimmune for rheumi type of conditions, whereas it's a little bit more physical in terms of osteo. There's now more and more evidence showing that maybe some metabolic factors that are linked to sort of osteoarthritis, which may explain what you were saying there in terms of late 30s, early 40s getting it. And if we think more around that as well, in terms of over the last 40, 50 years, living conditions, diet, so people more sedentary, the food, they think about the food that's on offer, the amount
Or
of stuff that's in,
inflammatory.
the amount of stuff that's in the food, like, all those kind of, those aspects, diet's been, sort of probably less good as a general rule of thumb. And all these kind of things that are going on, and obviously, like, I see we talk this all the time, but again, outside factors like sleep, stress and all these kind of things. So it's kind of interesting looking at that in terms of, well, there's the stuff around those factors that are actually, so whilst there might be some job related issues, like especially like say shoulder, these are actually lifestyle factors that are affecting it. And we know there's obviously a big one is just your hereditary, like if you're more susceptible to it. So we've got to look around that, and then that's how we then. So how do we get someone in with like osteoarthritis? How do we manage that condition, allow them to have pain-free or better quality of life?
What frustrates me with arthritis is fear, or people's fear and acceptance, basically. So what I mean by that is accepting I've got arthritis, and what they generally do is just down tools, and they go, oh, my knee's knackered, so I'm not going to do anything with it. And they sit in a chair, I can't do that because I've got a bad knee, I'm just waiting for a knee replacement. Why anyone would want that is beyond me. If you can do things that can either massively delay it or prevent you having it in the first place.
Or speed up your recovery post-surgery.
Yeah, or actually get to a point where if you do surgery, when you come out of it, you're in a much better condition to start with. But people just accept it, they sort of sit back going, that's me, I'm defined there by an arthritic knee. And they just wait for a knee replacement, which we all know is a pretty extensive operation to have in the first place.
Major surgery, but they think it's the be-all and end-all and it's going to fix all the problems, which is quite the opposite. And by the time you've had it, then you've had it, haven't you? And you start working with it. And I never understand, and it's you sort of touched on it in the last topic, where you might take 1, 2, 3 sessions to try and coax somebody out of that mindset of you can use this. So, I mean, it doesn't mean, all right, let's not go and do really high explosive, high impact exercises, but there's a million and one other things you can do, which is going to benefit this joint. Might be something completely new, an exercise or a sport that's completely different than what you're used to in the past. But the acceptance of, I have a bad knee, I've got an arthritic knee, that's me done. It honestly infuriates me, it really does. Yeah, and it's like you say, in terms of movement, it's move your joints so they're not as stiff, but also work the muscles around them. And I sort of use the sort of vision for people, especially those that are a bit more fearful. But it's like if you're working your muscles and you're strengthening them, you're offloading that pressure on the joint, that weight on the joint, and it's distributing that load then, so that pain will be reduced, but also that joint's being preserved for that little bit longer.
Yeah, and I think you both said about fear. Fear reduction is the biggest thing, and also part of that is the connotation, and that's the problem. Like that's why I was joking and saying that before about those words, because people see and hear arthritis, they see people who are really struggling with arthritis, and then so for a societal aspect, if you say arthritis to someone, they're then gonna, the connotations that can build up, the barriers, the fear, all those go like that. So what we have to do is try and, let's say, reduce that fear, but also help them understand that I sometimes say the word, I'd be a bit silly, but I say arthro changes. So arthro being joint, obviously, and then stop using that word, because as soon as if you hang on to a word, one that can create fear, or what you just said, it defines them. They go, right, well, I can't do this.
Yeah.
I can't do that. I can't do the other thing. What you were saying there about the knee and the strength is so Dr. Claire Minshall from Get Back to Sport, she does loads of work around this. So she's a sports scientist by background, but does loads of work around this type of area. And her analogy was, it's a scaffold. So so that, like you said, uploading. So your muscles are the scaffold around that. And now what's brilliant is there's overwhelming evidence that strength training is really, really good for like sort of, like I say, arthritis. And if you've got arthritis, don't sit in a chair, get to the gym.
Yeah.
Get to the gym and do the strength work. And there's a recent sort of a meta-analysis, which the British Journal of Sports Medicine released, showing that actually there's too many total knee replacements. And actually when they're getting to that point, but they're being failed at all these steps, and actually you could stop a lot of, or reduce the amount of total knee replacements that are occurring.
Yeah.
And actually,
I
and they looked at it. That's not just from well, they could do this, that, and the other. It's more from they're looking at systematically how our system works and how they get to that point, because that's partly the nature of the way the NHS is working. That's not criticism. It's just that's the model that's being used, but the demand's probably massively increased, and probably there needs to be adaptation now, because 30, 40 years ago you could probably get away. It probably didn't matter too much, but with an ageing population, more and more people think the expectation is you get I need a knee replacement.
Like you said, going back to the surgery as a quick fix, but it's certainly not.
But it should be replaced before that.
Yeah,
There needs to be things in place, and that's what. And I've had a couple of cases recently where I've seen them post-op total knee replacement, and it shocked them how painful it is. It shocked them how long it's going to take.
Yeah.
And I think again, it's all my Dave at the pub analogy. Oh, Dave got a knee replacement. He's feeling great.
Yeah.
That might be the case for some, but actually quite commonly, probably I would say more knees and hips. The process is slow and painful.
Yeah.
So again, it goes back to what we always talk about education, understanding actually, like you said, it's not a quick fix. But also, there's actually a lot of things you can do at the very, very start of osteoarthritis to potentially reduce or certainly delay that need for an operation.
And in terms of knees as well, it's important to point out, like especially knee and hip replacements, both major surgeries, but knees, like you've got 3 joints in your knee, your hip, you've got 1. And I often see the hip, like you say, it's not the individual, obviously, it's to take that into account, but your hip recovery is pretty much more straightforward, but knee is a bigger recovery. But also it's important to move and to strengthen. And I've sort of seen people pre and post surgery, and even if I'm treating them before, I say, point out it's important to see you quite soon after. Obviously, your initial things after surgery, as with all major surgeries, your wound, infection control, that's a priority. But we do need to start on the hands-on. We do need to get cracking on with the strength, because we need to get that new joint moving, because it is at risk of stiffening up. And not to be scaring, but it is much rare. I had a lady that's happened to more so through COVID, because obviously the world was a different place, but it effectively failed. A total knee replacement failed because she wasn't out moving. She couldn't get out moving, but she could have moved in the house. But it was the fear thing. She basically wasn't doing anything. And the poor lady, she's just got really limited movement. And obviously it's more like we just have to deal with it now. When she's seen the consultant, he said, I'm sorry, but in rare cases it can fail. But I know it's because of the things weren't put in place afterwards.
This is one of them sort of conditions, injuries, situations, whatever you want to categorise it as, which from my point of view can be what massively frustrates me with anything, but this more so than the most, is when you get someone who wants help but won't help themselves.
Yeah.
And unfortunately, with anything injury-wise, you've got to help yourself in a certain degree. So if you're continuing to live a sedentary lifestyle, you're continuing to eat processed foods, drink copious amounts of alcohol. Again, I know it's not a blame factor, but overweight, inflammatory, massive on your caffeine, low on your activity, low on your movement, playing the blame game, all this type of thing, whatever it might be, but then expecting 50 minutes with us every once in a blue moon to be the cure of all things. It just isn't going to happen. But people sort of lump that on you. There's my problem. You fix it for me. I was like, well, until you take on board all the educational things that we're saying about diet and lifestyle, it's just never going to change. And it's the one thing that really sort of grounds on me, that where people just sort of sit back and wallow in self-pity and then just, it is what it is, and just let it happen.
I'm going to butt in there though. I know what you mean, the majority.
Isn't. I'm not pointing a finger at anybody. Yeah. This is just, you do get it where they just won't help themselves.
No, but I have got a gentleman, he's early 60s, and he has got knee arthritis. And we've had many a conversation about trying to do things like go to the gym, but I get the whole gym's not for everyone. We can do things at home, and we've tried to adjust that, and he just can't. But I know that it's more of a, for him, a psychological barrier in terms of mood. But more recently, he's been on a couple of holidays, and he's doing a lot of walking, a lot of steps. And for him, where his arthritis is in his knee, he actually benefits from that because it's movement, it's strength. Obviously, some arthritis they'll struggle more with walking, but for him, and I have to keep pointing out if we can even try and go back to where we were on holiday because we were moving more, you're strengthening more. It's a much better condition because you might be now going to be on the waiting list for a knee replacement. That could be 1, 2 years, we don't know. And in this meantime, we can't just sit and wait. We've got to do something because your quality of life and your mood is continuing to reduce.
Yeah. The holiday's a good thing, actually. How often do you see it? How much of an influx do we get in winter of arthritis people coming in?
Yeah.
Arthritis people, bad thing to say, but people with arthritis in winter, we see it a lot.
Yeah.
Coming into November, December, through to January.
They feel it in the bones.
Feel it in the bones, it's cold, it's wet, it's all that type of stuff. And then, surprise, you get summer, nice day like today. Oh, it's lovely, it feels great, my elbows are fine, knees feeling good. And the explanation is, there is a big explanation in terms of weather and temperature, and it's to do with atmospheric and biometric pressure. Pressure in the air around us, a compressive force in the air around us. We get less of it in winter, so there's less compression around the joint, more chance of inflammation to spread, diffuse, whichever. And then in summer you get more of a compression in the joint, which feels a lot more pleasant, a lot nicer. So there is a seasonal aspect to
because I looked that up because I was like, keep getting is this all wives' tale? So that's why they can tell it's going to rain because when it's going to rain, the pressure temperature, the pressure changes. Sorry, and that's why. So that is one of those kind of quirks of nature where it's not people just saying it.
But also, I'm just going to touch on that. So, one of my clients is quite spiritual, not as scientific. But he did say to me once, and I thought he's got a good point there. He's like, how's the sea controlled? It's controlled by the moon. It's controlled by like the earth. And he said, but what's our body mainly comprised of? Like water. And he was like, so when there's a full moon and people say things or there's weather changes, because I think I was speaking to him about like the barometric headaches, and he was like, what's that about? And he went, well, actually, to be fair. And it was just quite a good conversation because he was coming from his point of view and I was coming from mine, and we kind of got together and I was like, you know what, there's actually a point there. And sometimes you notice, like you say, them patterns with like weather or people coming in with certain things, and you think, it's a good point that, like, maybe there is something in it rather than just an old wives' tale.
It's funny actually with that. This is nothing to do with arthritis, but just on the moon topic. The lady that comes in, and I remember coming in once she's a paramedic before she went to work, and said, "Oh, you ready for work?" She's like, "Oh, it's going to be a rough night tonight." I said, "Why?" She went, "Full moon," and I laughed, and I was like, "What are you talking about?"
The wolves are out.
And she was like, "Honestly, everyone goes mental when it's a full moon. All sorts of stuff goes off." She said, "Police, fire brigade, paramedics, they're all rammed with full moons."
My mum said this,
because it sends people mental.
She used to be a nurse, and she used to say that they'd say about the patients. All the nurses would say, "It's a full moon tonight." They're all like they're on one.
Yeah, I always thought it was like I said, a bit of an old wives' tale. There's got to be something in it.
Yeah.
So, but it's a good point. Actually, like I said, we are full of water. So whether there is a
relation,
So we'll have to have a look at that. That'll be our next.
You can look at your scientific research.
Our next podcast, like
British
water.
medicine and British Journal medicine on him.
But there lies the point. There's all these little factors, like I said, joking aside, people always get cold wear and tear, but actually there's those other factors like your lifestyle, other sort of comorbidities, so other diseases basically you may have, but then that metabolic link now that's really coming out, and sort of that's kind of really interesting. And I suppose ultimately what we're saying there is rather than wear and tear, the other phrase that people like to say is there's a lotion in motion, isn't there? That's what we've got to keep. Lotion in motion.
Lotion in motion.
So basically, move the joint. It keeps it nice. That's it. Again, it's not exact, but it's just a good. In terms of psychologically, it's a more positive thing to think about, isn't it?
Talking about that as well, in terms of arthritis, I think it's just important to point out the grading system. So obviously, in order to we've got a pretty good idea with sort of clinical assessment, and that's sort of subjective with the client whether we think it's arthritic symptoms, and then we can kind of gauge sort of how severe it is, but we might want that sort of confirmation via x-ray because it is a bony condition. You can get that via x-ray, which is pretty good. It's a cheaper screening to have and through the NHS, so it's quicker as well. And that generally gives us the grading system up to like 1, 2, 3, 4. So you've got like your mild, your moderate, your severe. Severe being more when you'd be taken into account for whether you'd need sort of total or part or full joint replacement surgery. And in terms of the management point of view, what we cover as well, so obviously manual treatment, strengthening. I think it's just important to just touch on like injection therapy as well. Obviously medication, that'd be something to discuss with GP, but like we obviously got an amazing advanced practitioner, Katie, here at the clinic, and she does cover injection therapy, which is generally speaking steroid or ostenol. So they both work slightly differently, don't they? So your steroid is sort of like you get your relief quicker. Your ostenol can take a while to kick in. It might be up to sort of a 6-week process.
So your steroid is your natural, your classic anti-inflammatory.
Yeah.
That's going to reduce that. So obviously arthritis being inflammation, it will reduce that inflammation, maybe reduce those symptoms a bit. But obviously the ostenol might help in terms of, we talk about the metabolic aspect, it might help with the lining and stuff.
I say that's like your lubrication that's reduced in your joint. It's kind of injecting that in your hyaluronic acid to juice up that joint.
Exactly, yeah. So there are sometimes strategies that we will suggest. And the good thing about Katie, like you said, she'll have a chat and she'll work out when it's appropriate, and that's the key word. All these things, from surgery to medication to injection to scans, very useful with an appropriate nature.
Exactly, yeah.
With your lubrication topic there and analogies, because again, it's a tough language in it. It's basically Latin, what you're talking to people. So
anatomy is Latin.
Anatomy is Latin. So we want to try and sort of dumb it down. Not dumb it down, but obviously make it more user friendly.
Yeah.
And explanations. And the lubrication of the joint, the synovial fluid, the sort of description I tend to use is almost like oil within the gears in the engine of your car.
Yeah.
If it's left stagnant, it's left sedentary, so it will be all claggy and nasty and horrible until you turn the engine over. It gets through your filters, it starts getting a little bit more fluid-like, should we call it. And it's the same process with the knee. People are always surprised that it's stiff when I've been seated for a while, but when I get up and I get it moving, it always feels better.
Yeah.
And the description I always use is you use your cartilage as disc sponges. So your disc sponges, when you wring them out at home, that produces your nice fluid within the joint.
Yeah.
And then they reabsorb the nasty fluid, and then you wring it out again. And the compression and extension of your knee is what flushes it out.
Exactly,
It wrings out your disc fluid.
Like that analogy.
It absorbs the old, horrible, nasty fluid that's been mixed with bleeding, swelling, whatever it might be, inflammation within the joint. And that's all it is. All the movement is doing is compressing those disc sponges, flushes out the fresh fluid, the constant movement, reabsorbs, and it's a constant cycle of it. And it's not simple, but it's as straightforward as that. And often, if you give them that explanation, they go,
"It makes sense."
"Oh, I get it." That's
Don't
all
need
it
to be
is.
technical.
That's the point there, isn't it? That's why I'll sometimes I try to get that analogy across, because I say the thought actually is like it's going to be damaging to the joint. That's like you say there, when there's compression, fluid moves through that joint, and you're actually getting old fluid out, new fluid in, and then you get that, like you say, that sort of lubrication, which is important. It's massively important.
There's a current sort of debate, argument, whatever you want to call it, going on at the moment with, does running actually cause degeneration of cartilage, or is it the opposite way around? Does it actually grow your cartilage and make it stronger? Because like we know, tissue, muscles, ligaments, tendons, bones, whatever might happen, responds well to load. So progressive load through a period of time, they'll get stronger. Strong men have biggest bone density going because they're under excessive amounts of load, vice versa. And they say, why is it supposedly different with cartilage? And the theory is that actually that progressive long period of running will actually increase the density of the cartilage. Whereas obviously the old school method is, you're wearing it down, wear and tear, that type of thing. So it's just, but it's important to understand that it might not actually be the case from
Yeah,
well,
it
the
actually
classic thing, is that, I've run all my life, that's why.
Yeah.
But actually, I mean, there was that Lancet study that came out, wasn't there, with like over 30 years. And this is what's really good in terms of from a research point of view, over 30 years there was it 3,000 or 30,000, I can't remember now, but a large number of people monitored, both runners and sedentary. And there was absolutely zero difference in the prevalence of arthritis. So we know categorically that if you run or don't run, your chance of arthritis is exactly the same.
Yeah.
So that old adage is just debunked. So there's categorically running does not cause arthritis.
But just to butt in on that one, obviously, again, depends on the individual, because you might get some people that generally are running 2 or 3 times a week, and you might get people that are running 6 or 7 times a week, and they're doing like 80 miles a week. So,
but that's that's not really But I know what you're saying there. But if you think about that, they're like individual factors which we're coming back to.
Exactly.
If you're going to do something, like repetitive, then you're looking at they're going to be actually as a general runner, a general sedentary person. So you can't blame running just as a general aspect. Obviously, if there's training errors, then that's a different conversation. But saying that, again, you get people who run a lot, more than other people. So there's always nuances. I mean, but in terms of just that old people blaming running as being bad, and even to the case now, there's some evidence that running can actually be, with arthritis, can be good. There's some evidence about that as well that's coming out. So we've just got to, I think, it's understanding arthritis and changing our mindset around it, because you can't.
I mean that conversation there between do you run and you have arthritis, it's that you can go down the world's biggest rabbit hole on that, and you can start talking about cadence, volume, intensity, track work, hill work, trail, road,
It's not just
footwork.
There's
a million
runners.
different.
Could be a rugby player.
There's
football.
like I said,
Squash. I'll be playing squash on the way.
It all comes back. It all comes back to what we say in pretty much every video and every person we ever speak to. Is that whole individual thing? Like we again talking running there. You've got somebody who can run 80 mile a week. To Bob, that's an insane distance, but to Mr. 80 mile a week, he might actually be used to 120 mile a week. So it's such or 120k, whatever. It's such a huge sliding scale. It's just understanding that individual. They might have a family history of arthritis, which is probably the biggest risk factor anyway. So it doesn't really matter if it's the runner. It's more because the dad had it, or the mum had it, whatever it might be. So it is just.
In terms of, like Maria said, with the training area, it is something to consider. You have to look at how those training areas linked in with that as well. That's the key. And then how do you manage? So if they've got a low level and then they've got training areas on top of that, if you reduce those training areas, then you can reduce the risk factors.
Those ones that we're talking about, the sort of more higher intensity or higher volume clients that are sporting, it's like we'll talk about like preservation as well, because I've got a lady and she's really competitive, like she's sort of like sub-3 marathon time, and she's like early 40s, but she's aware she does want to run. She wants to be able to continue to run when she's 50, when she's 60. So it's it's nice to work with her because she's open to what I'm going to say. It's like, right, what is yours to turn goals in the next couple of years? And then we really need to look at like changing what you're doing, changing like your volume, changing your type of training, because we want to preserve, longevity, we want to preserve your body so that you can continue to perform at a pretty decent level for as long as we can. So I think it would just be good to maybe change subjects a little bit, because we're very passionate about arthritis, osteo, to maybe just talk a little bit more about rheumatoid arthritis. Do you want to hit us with your geeky bits on rheumatoid arthritis?
Loved it, this lad.
Well, I don't know. Well, it's just, I mean, it depends. I don't know. It depends what you read. It's a bit open, like say, tell me a joke. I don't
okay. So just how it's obviously a bit more systemic, autoimmune, how obviously it's different to osteo, and how it might present in the body. Obviously, your most common joint areas we might see, what sort of ages we might see that from. Is there any sort of...
well, it can. It's one of those. It can hit people at a lot of different ages. I think again, it's stereotypically more, elder population. I personally see a lot in wrists, so I get a lot of people who kind of like that's kind of wrists and shoulders, like kind of symptoms, and then we're looking, and obviously you can get some sort of ankylosing type stuff around the lower back as well. That's kind of a classic one. And we're just looking at how basically, I think really it doesn't need to be too complicated. It's like I always talk about it being autoimmune systemic.
Yeah.
You know, looking at, obviously that's why blood tests are really key, getting those looked at, seeing which medication, obviously.
And going back to what we're saying about the moon and the weather, rheumatoid doesn't tend to be more effect. You know, it's kind of year round. So it can just be something else that triggers it, like stress, lifestyle, diet's a big one. So talking about that sort of, you know, what's going on inside, alcohol's a biggie. I've got clients that maybe I haven't been, or clients I say, particular ones I can think of at the top of my head, they mightn't have been diagnosed with rheumatoid arthritis, but some of the symptoms are just flagging a few different things to me, and I'm thinking, and they know, they're aware that when they've drunk alcohol it might initially relax, but days, weeks after, it's kind of set off a bit of a fire inside. And
talk about systemic and
pain,
the inflammatory response. Basically what's going on is that it's the body's being counterproductive, so it's doing the opposite, where it's, rather than sort of being
helping it,
preserving it, it's actually sort of attacking it. I mean, and that's obviously looking at enzymes and all that kind of stuff. You know, how they're affecting the cellular function, the hormonal responses, all that kind of stuff. And it's about you've got to try and readdress that, which is why some like methotrexate and stuff is used. So that's quite a strong one. But really, in some ways, I think there's a lot. Whilst there's differences, there's similarities. Okay.
Yeah, with osteo,
diet, exercise, sleep.
Yeah.
You know, good lifestyle management, and all those kind of factors are. Yeah, but it's good. It's good.
I know a lot of people, like when you're doing your initial subjective, you say, you know, have you got any family histories? You're kind of going through all the different pathologies, and they might say, well, my great grandma had like funny shaped fingers, maybe she had rheumatoid arthritis, but it's much bigger than that, isn't it? Obviously, like you say, it's multi-joint, so you can get people having these flare-ups from, you know, the toes to the knees to the hips to the wrists.
You tend to get it bilateral as well, don't you? So it's both sides. One needs both things. Oh,
Police coming fast.
Police come and get in there. It tends to be bilateral, both sides, and generally, from my point of view, you tend to find people have other health implications as well. It's not just I have rheumatoid arthritis. You tend to see it sort of coupled up with things like fibromyalgia and things like polymyalgia. And again, that's on your subjective assessment. That's where your medical history is crucial, really, rather than just saying, "Oh, I've got a bit of a dicky wrist." Yeah, it's actually looking far deeper into it.
Yeah, I think that's a good point there. I think we can sort of get diagnostic, because we don't diagnose. Where, you know, anybody who says they can diagnose just by that's without any tools is lying to you.
They've not got X-ray vision.
No, exactly. They don't have it. So that's
educated guessing, I always call it.
Yeah. Well, clinical impression is what we got told at uni. So that's the fancy term. But the part of the story there is, we could get the idea, but we need, with the osteoarthritis, you might, like, say the X-rays are really good, but something like rheumatoid stuff, you want bloods, maybe some of the different scans, a few of the things around that.
Bloods,
and that is markers, exactly. So we're looking for those certain protein levels, certain things that are going to show us, right, and then from there, then with the right medical team around you, so we can be part of that. But obviously, you've got your classic rheumatology team as well, getting every aspect, like the jigsaw piece, right for you, and then you can go forward.
And I've often, over the years, when I say often, because I feel like there is the whole going back to, you know, all the other inflammatory markers. I've sometimes had clients that are presented with rheumatoid type symptoms, but it might be, you know, something just doesn't make sense, and I'm kind of pushing for those bloods, pushing for those markers. They come back and they're all fine, and I just think something just doesn't tot up, and I've sent them back to the GP, discuss what's going on, and it might be something like a deficiency. I've had a couple of cases where they've had really significantly low vitamin D, and they've actually been presenting with rheumatoid symptoms, like quite severe, intense, generalized joint pain, like a lot of fatigue. And, you know, once that vitamin D was improved, they couldn't believe it. It was like a switch. It's really improved.
Yeah, I've had that with, was it calcium or something as well? Something like
calcium,
really, sort of low level. So just and this is the thing. So it's not, you know, nothing is, but sometimes these things, like with rheumatoid stuff, it's not black and white, and there's a lot of tweaking. Like with the osteoarthritis, you can sort of, you can be a little bit general specific, if that's such a term, like
A bit more black and white, yeah.
strength, range of motion, etc.
Yeah.
Well, yeah, black and white with his the
Yeah, rheumatoid's a bit grey.
You've got to be. There's a lot of nuances.
Yeah, there's
Yeah.
a lot of tweaking.
Right,
Yeah.
so that's a good. I think we've chewed a lot of fat on that. Hopefully, you've got some good information. And also, what's good there as well is that some good viewpoints there for slightly. So not necessarily everything we would say is exactly the same. There's a slight variation of a theme, which is kind of what the point of these videos are. So until next time, thanks very much.